Okay, so once more, thank you very much for joining us, and it's a pleasure and an honor for us to have amongst us Dr. Shyam Vasudeva Rao. We met him through our good friend Dr. Arvind Chinchure when we were organizing an event together with the German Research and Innovation Center, DWIH, in New Delhi.
Yes.
So I think it's almost 3 years back, of even 4 years, 2017, I think. Together with the German embassy, we organized an event on frugal innovation. And after that, it has been actually a series of events. We were so inspired by his works and so much influenced also by a couple of things. It's not just one thing. Dr. Vasudeva Rao is, apart from being a very knowledgeable person, a very humble person from whom one can learn personally something, he's also a great innovator, especially in the field of frugal innovation and in the field of global innovation, so that he matches our course perfectly, I would say. And I'll introduce him very briefly, and afterwards maybe he can say a few words about himself. Dr. Shyam Vasudeva Rao is founder and director of Forus Health Private Limited. Even this name is very deliberately chosen, for us. So the community orientation. He is also technical director at Maastricht University, Faculty of Health, Medicine and Life Sciences in the Netherlands. He is co-founder and director of Renalyx Health Systems, e-health enablers, all in Bengaluru. He is also the chief mentor of Center for Innovation in Medical Electronics, BMS Engineering College, co-chair of FICCI Medical Device Forum, and executive board member of ASSOCHAM Healthcare, both very big industry associations in India. He has been doing innovation work now for, I would say, more than 30 years, maybe it's even longer than that. His first innovation was a hardware antivirus solution called Knoxcard in 1989. And he has worked with all big global names in the global innovation field. So he has been with Ericsson, with Philips, apart from his own work. I think if I read here, then at Ericsson, Dr. Shyam was responsible for building an R&D team of more than 100 engineers for new product development activities at Bengaluru. After this success, he was on a special assignment at the head office in Stockholm as a strategic product manager for over 2 years. This involved building revenues and profits through innovative and creative business strategies and extensive customer-centric business analysis. Working as a director of technology in Philips Innovation Campus, Bengaluru, he established the innovation framework for consumer electronics and medical systems division. He exponentially grew the patent portfolio of both the above divisions and established working relationships with academic institutions. He did his PhD at the Indian Institute of Science, which is the most reputed academic institution in India. And he was awarded a gold medal and a best thesis award for that. His innovation, Trinetra, which is like 3 eyes or the third eye, and all in one eye screening device at Forus has won several laurels, many awards, like the DST Lockheed Martin Gold Medal, Parimal Award, Sankalp Award, CNBC Award, Samsung Innovation Quotient Award, NASCAM Innovation Award, Anjali Mashalkar Inclusive Innovation Award, and he has been IoT India Congress, or he was awarded by them an IoT Thought Leader award. So all in all, you see that he's a highly accomplished researcher, an innovator, an entrepreneur who has published more than 40 technical papers, more than 25 international patents have been filed, Many of them have been already granted also from the USPTO. So you see that we have here amongst us someone who can tell us a lot about global innovation, about frugal innovation. And before I conclude and hand over the floor to Dr. Rao, I would also like to say that through interaction of him, I got many ideas. I was inspired in my research on many fronts. And if you remember in our previous session, we discussed about frugal innovation. And one of the characteristics of the definitions that was used traditionally was that frugal innovations are concerned with reducing the number of services. So they have to be very reduced, a very limited number of services. But in my interaction with Dr. Rao, I found a device where he actually enhanced the functionality and created a frugal solution. So that gave us an idea that ultimately it should not be about whether you are reducing or you are enhancing. It is about being judicious with your resources. It is about being appropriate. And it is about solving a problem with the lowest possible total cost of ownership. And keeping that in mind, you can be changing things. So as you see, I've been really fascinated by the work that he has done. And I'm sure I'm not just speaking for myself. My colleagues, Stephan, is also as much involved in this research and in our interaction with Dr. Rao. So we look forward to your talk, Dr. Rao. We are very pleased that the digital transformation has allowed us to come over virtually and join us in our talk. So the floor is yours. And just one comment, if you have any questions, Dr. Rao has said you are free to speak or raise questions or comments. As usual, at any point of time, he encourages a free discussion. And with that, the floor is yours, Dr. Rao.
Thank you, Professor Rajnish and Professor Hestad and Stephan for giving me this opportunity. And it's a wonderful opportunity to talk to these young minds and, really deliberate on things which we see day in and day out, how the entire phase of innovation is changing. So I will quickly start my presentation so that can you see my presentation?
Yes.
Okay. So just to make it easier. So the title, as you see, I want to really, the frugality of the whole thing is that how you can get more from less. That is the mantra now, So how we try to apply this for healthcare. Earlier, when I was working in Philips as a innovation manager, I was always thinking that it is only India which needs all these low cost and optimized solutions. But then we see that the same thing is applicable to the rest of the world. And then now if you see, even the most rich countries also, like for example, even Germany and all, everybody is looking for how you can get more from less. So that is a very important aspect. And the beauty of this is that these are more sustainable. If you have very expensive stuff, then it is not possible to sustain it for a long time. And if it is something which is frugal and which is cost effective, then it is more sustainable. So that is the idea. And now we can see even in the auto industry and everything, we are seeing there are a lot of BMWs and Merck in on Bangalore Indian roads. Even in smaller places in India, we see them going around because they have also done so much of advancement that they have made the entire thing right, from an affordable to very high end, that sort of a range. So let me get to my this one. So the so everybody talks about some 6 pillars of frugal innovation and all that. To be frank with you, I did not know anything about this when I started, and these are new terms what I learned. But then, if I try to trace it back and map it to the work what I was doing, yes, they fall in this category. So we need to really see, what is that we want to do. That is, the design thinking is what is the basic, I would say, fundamental to any frugal innovation. Because design thinking is the one which will help us to look at the opportunities, empathize, and see where the opportunities are. Any innovation we do should ultimately reach the end objective. It has to reach the society, and that is the motive. So I would say that to seek these opportunities, it is always good to do a design thinking, and definitely, as this says that more from less is the real important aspect. So optimization is key in today's world, because we don't have products anymore. We only have services. All our products are converted to some service and delivered. Nowadays, if you see, nobody wants to buy a MRI or a CT scanner in India. The hospital say, well, you get the machine, put it here. I will send my patients to you, and you get paid for every service you deliver. So that is the model which is actually now becoming more and more prevalent, and this is also the case even in the Western world. I was looking at Butterfly, a company in US. They make ultrasound, but they don't do ultrasound machines. They give it for free, and they charge per scan. You see, that sort of a thing, or per report, I would say, not even a scan, per report. And that sort of a model is what we see more and more happening, and the cost of ownership and all that reduced. So that is the idea. And we need to think about flexibility in whatever we do, because what we see is, a lot of things are regulatory driven, which is very rigid. Obviously, they have to be. But then as time changes, and then things are, the technologies are becoming more and more intuitive, more and more easy to use. I think there are certain flexibilities also which can be brought in along with this. So that is where we see that there is a need for thinking of how we can make it flexible and keep it simple. And also we need to see, where we see the margins, because either, these projects are uh, under budget or over budgeted. So if we are working with a consortium approach, normally everyone, will try to put in as minimal as possible. And, most of the time we end up, without proper funding. And that sort of problems are something which I see, and that is where we need to include margins in the beginning itself, and they have to be reasonable. And you have to follow what's your passion. That's the most important aspect. So that is these are some things. And in all my work, what I will talk, you will see these aspects in them, and we can actually debate on that. The healthcare of today is very different from what it was a few years ago. It is no more, a single object or single it's one like, okay, I have a hospital for cancer. Okay, I'm going to treat all cancer patients. It's not like that anymore. We need to look at it in a broader sense, and we need to also look at it from not the treatment angle, but also from the preventive angle, and see, how we can catch these problems at a much early stage. So this is applicable to almost all the non-communicable diseases like diabetes, hypertension, cancer, COPD, any of these diseases you take, they all, have this need this continuum. The early intervention you do, the cost is less. But overall, if you see, you are earning much more. It is like the concept of sachet. Instead of selling a 1 liter shampoo bottle, you start selling it in smaller packets of, say, 15 ml or 20 ml, which is maybe just sufficient for one use. Then, if you put that together, the person would be earning 2 times the cost, 2 times the revenue, of this whole thing. So that is the model, and this makes it more affordable. Everyone can start using this, right? So that sort of a thing, and it also makes it very mobile. You can use it wherever you want. Okay, it is difficult to carry a 1 liter bottle everywhere, right? So that sort of a thing. So there is a lot of this. So the same thing applies to healthcare also. We reach out to the people at the right time with the right screening or with the right technology. Then you try to detect the problem at an early stage. As soon as you detect them, connect them to the right service provider. Maybe it is hospitals or to the specialist, or it could be to some sort of a AI-based app or machine learning-based app, and or it could be to a community. There may be a Facebook group or a WhatsApp group or a LinkedIn group, which actually will be in a position to connect this person with what their specific problem. So it is not always the doctors who can actually solve the problem. It could be a lot of other peers also who can actually solve problems, and that depends. That's the connect, and then you treat them. Treatment is also today confined to only the bigger cities and all that. I'm talking about this in the country like India and the developing countries, and they're all centered around the big towns and big cities, whereas there is a whole lot of population in the rural and tier 2, tier 3 type of places. So not that they don't have money, they have a lot of money, but it's not easy to get the treatment because there is no availability is not there. So we need to see, if we can make these sort of portable ICUs, all sorts of things. Today everything is available, and we can see that COVID has given a real opportunity to test this out, and then people are using this and then sustain it. In Germany, you have a very good healthcare system, and there are insurance and all that. The government takes care of it entirely. But in a lot of other countries, there is not that type of insurance and all that. So there we need to see how to sustain this, because it's a continuum. Okay, so this is the thing which has given me so many ideas, and I've put them out here, and you can see each of them, is something which is worth exploring and worth innovating. And a lot of things are happening. This is around 8 years old slide or 10 years old slide, but I see that it is still very relevant in terms of finding the opportunities. And then I try to see, you try to map it out to the hospitals. These hospitals today, if you see, they are not properly balanced as far as the revenues are concerned. You have the hospital with the inpatient and the ICUs and all that, which is basically the one which needs a lot of equipment, and they are they are the ones who capital like would be spent on. And then there is the outpatients and treatment, rehab and all that, which is basically the one where there is not much of equipment and not much of complexities, except that there is some doctors to consult and all that. But then if you see, the patient volume is high in this low cost area and low in the high cost area. So there is a disparity here. And this disparity leads to a lot of trouble. The hospital, if you say, the person who has invested in the hospital would say, I would like everybody to get into the inpatients and get them into the wards and make some treatment, give them some treatment or something like that, right? But then there is a problem that who will take care of these inpatient, outpatient departments, consultation, counseling, and treatment, rehab, and all that. So that is why, if we can do, and for the patient also, they have to come many times, visit the hospital for the consultation, and also for a checkup, and or for rehab. For example, those who are having a kidney problem, kidney failure, they have to go for dialysis every alternate day, right? So this is basically causing trouble to all of them. So that's why, is there a way by which we can split this? So move the outpatient department to camps, health kiosks, homes, and all that, so that this can be done much closer to the patient. Okay, and also treatment, some of the treatment and rehab, basically, like dialysis. Now, if you see, there are a lot of companies, which are starting dialysis at home. So this is becoming very, very popular in the US. This was one which has been proposed by by Trump, actually, and I think they are taking it forward now. Also, they want to see how institutional dialysis are discouraged and home dialysis is encouraged, so that we bring down the cost of direct costs, like the institutional overheads, and at the same time indirect costs where the patient has to go and get the dialysis done and all that. So that way these sort of things are basically now being tried out. So with that, and through the IoT or IOMT, Internet of Medical devices or medical things, we get connected to the ICUs and to the main hospital. So in the process, what will happen is only those who really need hospital care will be moved to the hospital. Today, if you see, there is a huge shortage of beds, COVID beds, in India. And more than 70% of them are not needing that hospitalization. But it is the panic situation. And it is that they can afford this. So they want to go and just grab them. It is happening also to these oxygen concentrators. The moment they hear that they have a COVID positive, oh my God, I have to buy one. Let me book a bed and also, buy one concentrator and keep it at home. So that sort of a thing. So because of this panic situation, you see, there is a whole lot of chaos. And that is the situation. That is the problem. So if there is a way by which we can triage them, today there is so much of AI, ML and all that. If we can triage and see to it that only those who need this treatment or who need the attention in the hospital, they will be moved to the hospital. Rest of them can do it with teleconsultation, telemedicine and all that. And there are so many other ways by which, we can do these sort of things. So with that, we are trying to optimize the hospital system. So this is the thing. And this was the concept on which I've been working for my ophthalmology and also nephrology. So let me take one interesting story here. This is the problem of retinopathy of prematurity. There are a lot of preterm babies born, and this is not only in India, everywhere. The numbers are more in these sort of countries like the developing countries. And every year in India, we have around 27 million births happening, out of which 4 million are born prematurely. These premature babies are born, before the 32nd week, and then they weigh less than 2 kilos of weight. So that is what WHO says, that these are the ones which are premature. And these premature babies have two problems. One is that their heart valve is not fully developed, or a heart is not fully developed. And the other thing is there is a problem with the eye. And the eye problem is a real-time problem, I would say, because it only gives 6 weeks time before which, you have to intervene and do some laser treatment. Otherwise, the baby is blind for the rest of its life. In India alone, we have around 200,000 blind babies put into the society every year, 200,000. And in Africa and all the other countries, there are so many, and that is because of the single problem called ROP, retinopathy of prematurity. So heart can wait for 6 years, they say. And after that, they can do a surgery and set it right. But for eye, it's just 6 weeks. So this was a very challenging task and a very interesting problem. and it's a huge burden on the society and on the country, and for the individual, of course, it's a very big burden because they have to live blind for the rest of their life. So we said, okay, what is that? How can we solve this problem? So this I started in the year 2013, beginning of 2013, and then did a real study on this. I don't know how many months I spent in the hospital, where they were one hospital called Narayana Netralaya, doing immense job in this area of ROP, and try to understand what is their problem. Their problem was, okay, first they said, well, we need a special type of a device to image the eye. Okay. And this device, these babies are actually very, very small babies. So you can see puny babies, which is on a palm top, you can hold them. And their eye is so small. And you have to image the eye and get the retina image. And this retina image has to be a wide field image, 120 to 140 degree field of view. Okay. And once you can see this image, then if there is a problem called ROP, you will see some sort of a layer in the eye at the peripheries. And this layer, if it is present, then yes, the baby has ROP, and that starts progressing fast and it tears the retina. Within 6 weeks, the baby can become blind because the whole retina becomes a lump. And that is a very terrible thing. And there are babies which may not have this problem also. So there is a need for triaging this. So for that, we needed a device. And this device, I searched, there is only one company called Clarity Medical Systems in the US. It's a Palo Alto company. Then they made this device and is super expensive, $160,000. In Indian currency, it is called 1 crore. It's a huge money. And $160,000 is not a small money, even for a big country or rich country also, right? And this device is a very big one, and it has to be carried and put, and you can do the imaging with that. But then it was more of a hospital-bound thing, not a field one. And now our issue is that we want to take it to the field and do the screening for all the babies which are born prematurely. And in India, these are done at NICUs. We have neonatal ICUs where these premature babies are born. Obviously, that is because we have a system in India called ASHA system, where the health worker, it's called ASHA worker. She will be in a position to bring the pregnant women for delivery to these centers, and they get some incentive for that. So that way we see all these 90 to 95% today, all these premature births are happening in the hospitals and these sort of NICUs. So, okay, but then this $160,000 equipment, it is just not affordable by these sort of small NICUs. So that's where, we said, let us see, if we can make something, apply our frugal technique and see how we can get a device for that. So we said this was a device that is in 2013. Already it was around 17, 18 years old device. The technology which was put in was 18 years old. So it had some xenon lamp and fiber optic, and that was illuminating the eyeball, retina and all that. Okay, that was a thing. And then it had a lot of patents around it. So you cannot do anything, if you use fiber, then you are gone, that sort of a thing. So it was really a tight, landscape, patent landscape there. And then the other things are like, okay, how can we overcome these patents, and then how can we make something which is simpler? So you start to track, okay, which year or which decade, this was done, and the technologies prevalent at that time would be used for it. And once a medical device is done, it is like, okay, there is no monopoly because you have the FDA and all that. So anybody who has to make a device has to go through a whole lot of regulatory and all. So nobody wants to shake the rock the boat, they say, right? So the business is going on. There is no competition. It's a monopoly. So they just go on failing patents and cover up their response. So make an entry barrier difficult for others. So we said, okay, the first thing I did is that, okay, I said, okay, now there are fiber optic, let us take it out. So we used wave guides, light guides from the automobile industry. You get a lot of ideas for light guides. And then, the auto industry, if you see there, we have done a lot of advancement, like we don't use anymore, those big lamps. We use only LEDs. So you get the same amount of light or more light actually by LED because of the light guide what you use as in the front. So that way we put that light guide and we put LEDs and totally took away the entire fiber optic business and power, high power, all those things. And this device we made with a very high resolution camera, and within 3 years we could get a device out which is highly portable, handheld, at almost 1/10 the cost or even lesser than that, and with around $7,000, $8,000, we are in a position to put this device in the market, and with a margin. Okay, that part what I was telling for sustainability, you need a margin. There is a margin. There's a margin, of around 35-40% actually on this. And with around 8 engineers and approximately $2 million, we could make this device. So that was the long story short. Okay, so the frugality here was to see how we can use low-cost technology, how you can use sustainable thing, like instead of using very high-powered lamps and all that, can we use LEDs, and these LEDs which are having special filters so that they don't throw blue light into the eye, because medically you are not supposed to use this blue light, which is very dangerous to the eye, right? So all these things, and with that we could come to this, we could get this device. Okay, the problem, we thought that if I make a device it will be solved. So let us see then what we do. Then you have a very interesting concept. Okay, I have done other medical devices, other ophthalmic devices, one of them Trinetra, which actually Rajnish was mentioning. So for that we had already a backend, the entire tele-ophthalmology system, and the cloud-based system which is there to screen people in remote areas and also in smaller hospitals. So the same logic, same software, we brought it to this device, and then at the NICUs we have the baby screened, the mother, and then there is a health worker who will be there to assist. So we create immediately a medical record for that, and then these images are actually uploaded onto the cloud, and we do some initial triaging, see whether there is a problem or not. And if there is a problem, or we find that there is some problem, abnormality, then we straight away send that to the doctor, a retina specialist, and on the mobile phone, the doctor is in a position to see this image and then work on that and give a report saying, okay, that there is a problem or no problem. If there is a problem, at what stage it is, stage 1 to 5, we have in ROP, and even it is stage 4 or 5, we call it as plus disease. The plus disease is the one which is dangerous, which will actually need laser treatment. So based on that, we have a workflow system on the cloud, which will actually decide the protocol. Okay, if this is of this stage, then what to do when it has to schedule the next screening. And if it is gone beyond a certain stage, then it needs laser treatment. So directly it will book an appointment with the doctor in the district hospital, because the district hospital is the one where you have specialists and all that who will be in a position to administer the laser for these babies. So, and then the mother and the ASHA worker, we say the health worker, they are geotagged, their mobiles and all that. And then on the specific date, they'll have to come and get the baby examined again or get the laser treatment for the baby. So this is the system which we put in place. And for this, we had to work with the eye hospitals and also with the government, because these people who are actually those who are at the bottom of the pyramid, they can't afford this treatment. They can't even afford travel to the district hospital. So that is the stage. So there are a lot of government schemes, and government has a lot of things for these people. So we have to connect them with the right information to the right the government has one. So they, through that we facilitate. So for them it is all free, and they will be in a position to get to the right get to the right time. So the screening has to be done within the first 3 days, because in our Indian system, these people will stay in the hospital only for the first 3 days. After that, they will go back to their homes, and it is very difficult for us to trace them once they are back home. So there is a kit which is given to them from the government, which has all the necessary things for the baby, the nutrition part, all the other things, checklist and everything. In that, they, for these babies who are born prematurely, we also give them a mobile, so that the mother is actually in contact, in touch with the healthcare system. So that is the thing. So that was something which we facilitated. So you see the problem now, what I mean to say is that more from less, how this is becoming relevant. We have around 4 lakh babies born every year. We have around 20,000 NICUs across the country. This includes public, private, everything. Okay, 20,000. More than 60% are private, rest are government. The private ones are catering to the bigger cities and also to the paying patients. Okay, but then they also need this service. Okay, so there is 20,000 NICUs. Then we have 2,000 retina specialists, and these are the ones who can actually see the retinal image and grade and say, well, this baby has plus disease or not. And we have just 200 pediatric ophthalmologists. These are the ones who can actually treat the baby with the laser. And if you remember, I was telling you 200,000 babies are put blind into the society. So these 200 babies could have been, we could have turned them, they could have got their vision if we could have treated them, right? So there is 200,000 to be treated by 200 pediatric ophthalmologists. So you can imagine this is really a big scarcity of resources. So this is the situation. So now, how do we solve this problem? So, okay, one is for screening. We have this one. I will come to that part. And then for treatment, we need a special method. But more than anything, on the field, we need somebody to do the imaging. And in this 20,000 NICUs, if we have, these doctors cannot go there. Obviously, they are only 2,000, they can go to the 20,000 ones, right? And they don't want to also, because these are rural areas and all that, they don't want to go there. So we need to do some special training, or the device has to be made so intuitive that even a less trained person can do the imaging. So that was the first task. So the device is done. It has been, we got CE certified, everything. It is good, world class, no problem. Good images, made good publications also in top journals. I have published all that. But then the treatment part, that is the thing. So conventionally, the treatment is done by, indirect ophthalmoscope and specialist, ROP specialist, pediatric ophthalmologist is in a position to hold a 20 diopter lens and look into that and all that. And they are the ones who are conventionally screening. So that is the CDC. So you can't change this, because that is a worldwide accepted thing. But then in India, we can't do this, or in these sort of countries. So what we did is first we said, okay, instead of the ophthalmologist doing it, we have a device. See, here is a device. This is the expensive device, what I'm showing there in the bottom screen. And this device, there is a technician who can screen. Okay, we train a technician to image the eyeball. So he is in a position to screen, he or she is in a position to screen with a 6 to 8 months of training. And then we got this several thousand of such screening we did, and then we got a CDC published through the Australian Medical Association. And there is a person who comes, a pediatric ophthalmologist, and then inspects, goes to these government hospitals, private hospitals where we are saying that this is done. And they finally publish this CDC, through which, now world over, the screening for ROP can be done by trained technicians. Okay, it's an optometrician driven program than an ophthalmologist driven program now. So that is the first step we did to build capacity. And then we started to go into the field, start to enroll more and more centers. In 2017, till 2017, we had the government of Karnataka to fund this, and we could make these many screening sessions, and 144,000 sessions, and around treatment for around 2,242 babies. And with this became a national program. And today we are there in all over India, and we have made this whole thing like, okay, device they can buy or they can rent. Training, everything is available online so that they can get trained. And the All India Ophthalmology Society has made a special ROP task force and ROP group, which actually helps in handholding and all that. So that way we are in a position to scale it up in a big way. So then comes the treatment part. So if you see treatment also, you can see that doctor is treating. He has an indirect ophthalmal scope with a laser, and through this lens, they are in a position to see the retina and then shoot like, carpet bombing. Okay, you can see that, the dots, white dots there. These are the ones, which the laser has been, administered. And in one treatment, they do up to 2,000 to 2,500 shots. So you can imagine, it's so strenuous. It takes 3.5 hours for a doctor to do this, and in this position. So it is really a painful thing. So a lot of them don't want to do it because they get back pains, and there are so many people who have got problems with that, and so the doctors also find it very difficult. So then now you do the screening, you get the patient. Now you don't have capacity to treat them. So that is the situation what we saw. And then we said, okay, is there a way by which they are doing treatment? How is it done? This is the gold standard. These babies, premature babies, they have to be in the incubator or warmer. So the warmer, is run of fiberglass, and you can see through that, they are seeing and doing a treatment. Why I'm trying to show you this is, and this is not only in India, everywhere this is how it is done. No? What I'm trying to show you is, most of the time, we aim at treatment means very accurate, very precise, very, very good, all that. You saw the treatment is like, carpet bombing, okay? The retina vasculature would have grown beyond a certain level, beyond 180 degrees inside the eyeball. And now when it goes further, it is going to bend, and then they start to rupture the whole retina. So what we do is by laser, we are trying to cut it off so that it doesn't grow beyond that. That's all what is done. So it looks very sophisticated, but actually if you see engineering wise, it is not that difficult thing. So that's why we said, okay, can we do some treatment one also? So for that, then the documentation, it is all done like this, it doesn't need a very sophistication. You can see, how they have documented it. They have shown the layer, which side of the eyeball that layer is growing, and they are also indicated, where the laser has to be administered. That's all. There is no big one here. So you can see the layer here, on the right side, if you see the eyeball, it has a layer. Left one is a normal one. So we said, okay, now to do this treatment, can we make a training kit? And quickly we took some, this is the kit, okay? This is again a frugal way of doing it. We have a VR headset, like you saw the doctor is, while they're doing treatment, they're wearing something called the indirect ophthalmoscope. And that is nothing but, like a VR headset. And then, we have this lens, okay? This is a equivalent of a lens. And then, we have markers, and then we have the smartphone, okay? I'll show you why I have the smartphone. This is for a VR thing, and any Android system you can use. And then there are some control buttons and foot switch, which is the one through which they are going to hit this one, then the laser is going to be administered. And then we made a mannequin quickly and put a artificial eyeball there, okay? And with that, yeah, so you can see that. And so with that, we are in a position to simulate exactly the thing which actually does the laser. Okay, so with that, we are in a position to train more number of doctors to do this laser treatment. So it's a simple Android phone, nothing complicated here. And we will just do some registration, okay, a VR registration. And this is a $15 VR headset, okay. And see, now they can see this. You can see the red dot, and is in a position to get into the eye. That is the speculum which is used to stabilize the eyeball. Otherwise, the baby may move the eye to eyeball. So they use a speculum. And this speculum, we have put pressure sensor into it so that, they don't press it hard. That is very, very critical, because for the baby, it is a very important thing. It can rupture the retina. So that's it. So with that, you see, we are in a position to train. And this training, we also grade them. And then after they have done sufficient number of hours and they have hit the accuracy required, then they will be taken to the hospital, and they can work with a senior person. And after a few weeks, they can directly start doing the treatment. So that is the thing. So there is no new thing what we have done here. It is only some software, and the rest is all, standard things which are available in the gaming industry. Bring them together, and that's what we have done. So this is and then you can see, after we train them, you see these are the eyeballs, which they have actually. This is the artificial eyeball, okay, and on which they have administered this, and it looks very natural. It looks like a natural eye. But then, okay, then we put in some smart features also. Now, with this, we are now in a better position to add more and more things. So we put smart features so that this is the area where, weak area. So people are not supposed to fire laser there. There are in the eye also. Macula, you should not touch the macula. Macula is the most important part. So by mistake also, they shouldn't fire there. So all those controls now we can do on this thing. So these are some things on the way, on the arteries also, they are not supposed to fire laser. So all these things, we can put a lot of lessons are there for them. And then with that, we are in a position to do the training. And this is my very good friend, Dr. Anand Vinekar, who taught me all these ROP and that's one. I've spent several now years with him learning this. So till now, he has done so many 50,000 infants. And if you see what is that we save for the nation, See, we could save around $194 million by saving these 50,000 infants by not getting blind. That is the loss of productivity, you can say. This is in terms of revenue only, but in terms of livelihood and all that, of course, you would have done a lot of saving, because all these people now, they are not blind. If not, they would have got blinded. Okay. So this is the example what I thought I will share with you people. And can I take few more minutes? Okay. So then there is another interesting thing, which is basically working with the ophthalmology and eye problems. We see that eye is not only a biomarker for ophthalmologists to detect normal abnormality or eye problems like macular degeneration, glaucoma, or refractive errors, or cataracts and all that. Eye is also an important thing, like it is the window to one's health. Okay, so this is the concept which has been there for a long time. But then the problem is, after these super specializations have come in, people who look at eye, they don't look at the other organs, for example, or those who look at retina will not look at the anterior part of the eye, okay, or the posterior part of the eye, the cornea. There are cornea specialists, there are retina specialists, there are glaucoma specialists, there are so many of them. So because of that, what is happening is that we don't get a single view of the whole thing. So what we say is, okay, we all know that, there is vision problems and all that for the eye. But then there is other problem like non-communicable diseases, like diabetes. In fact, more than 20 to 30% of the diabetic patients are caught by the ophthalmologists, not by the diabetologists or GPs. These people wouldn't have realized that they are diabetic. They would have gone to the, for eye problem, they would have gone to an hospital. And then when they see that, or on a regular checkup, they would have gone. And then they see that already, there is a diabetic retina formed in the eye. The vascular structure is already broken. There is yellow matter which is floating around in the vitreous, or there are some blood stains, all these sort of things. So with that, what we see is that diabetes can be detected. Cardiovascular diseases also can be detected, like the risk of getting cardiovascular problems. That is also, you can find out from the eye. Then Alzheimer's is another thing. Last year, one of my students published a thesis on, schizophrenia. So by looking at the vasculature of the eye, we are in a position to catch early stages of schizophrenia. So these sort of things, there are a lot of things, which can be done with the eye. But then, we need to now see after these equipment is in the ophthalmology department. And then the specialists are in other departments, the neurologists or the cardiologists, they are not there, right? So how do we bring them together? That is the thing. So that is where, we said, okay, this could be an opportunity. And that's where, we said, okay, we have made an autonomous eye system, autonomous system, where a person can go sit in front of this machine. This is put in typically, in public healthcare centers, or, in malls, railway stations, airports, or whatever, where, anybody can go sit there. It will automatically identify your face, your cornea, retina, everything, and take the images and upload it into the cloud. Okay. Now, once it is in the cloud, you can first do the diagnosis for eye problems, because there should be something which concretely somebody will get, right? So they would have gone for their eye test, so they will get the eye report. But then there is also, we can do detailed diagnostic, because this could be only screening. But then you want to do a detailed diagnostic, then, remotely, we can connect. They have to fix up a time and then, go to such a machine, and then they can connect with a specialist on the other end. So with a VR headset, the person is in a position to control the machine, movement of the machine only, and see the details of the eye or whatever they want to look at, and then they can do a detailed diagnosis. And once that is done, next, for treatment, we are also working on a laser system which can be integrated into this. So even the treatment can be done remotely. So with that, we'll be in a position to take treatment to the doorstep of the patient. So that is the next big thing what we are doing. And in this, I will show you some videos where you can see how this functions. So this is called iRobo, and this is already on clinical trials in some places. So the person has to identify themselves. If they want, they can enter the data, or if there is a Aadhaar, we have a unique ID. If they have that, then all the data will be automatically populated. Then there is a voice activated system. So it's in a position to align the one so that you get the image. Because we need the macula and also this. Yeah. And then for remote diagnosis, we have this, they would have booked another appointment. So they are in a position to get the detailed one. So the doctor is in a position to reach out to the patient in some rural place, and she may be sitting in Germany, Frankfurt or something, and then doing this. So that is the that is the one what we see. So I will stop at this and take questions.
Yes, and thank you very much, Dr. Rao, for a very insightful presentation. I was again quite fascinated by seeing the role of digitalization, the digital transformation into creating frugality. So how modern technologies can be used in creating frugal solutions that are affordable, and we define frugal innovations as affordable green excellence. Yes. So they are affordable, they are sustainable, and they are excellent solutions. Yes. And I think your talk today, the examples that you showed have highlighted that quite clearly. Also, what I was seeing is that you use a lot of what we call in innovation management inventive analogies. So seeing what types of knowledge is being created in different domains and whether it can be transferred to another domain. So learning from other industries, from nature, even bionics, so yes. Like that. And you emphasize the role for a holistic approach. Like you need a specialization, but you also need a holistic approach so that you have a systemic view. So it has been a very enlightening talk for me. And so thank you very much for that. And I would like to open the floor to the students and to the colleagues who are here, who have joined us. So anyone who has a question, please feel free to ask or just to raise your hand. And yeah, I'll stop the recording now, yes. So that you don't also have to worry about the recording that is